morning, everyone. We're going to get started. My name is Mark Doty. I'm here to open up day 3 of the Delaware Economic Summit and introduce Mr. Rich Shaw. Rich Shaw is President and Chief Operating Officer of Cardio-Kinetics. He's been with Cardio-Kinetics since their inception in 1979. He serves in adjunct faculty for the College of Health and Exercise Science at the University of Delaware. He's a member of the American College of Sports Medicine and past regional president of the American Heart Association. He has been a speaker of the National World at Work Total Rewards Conference, the World Congress Annual Executive Forum on Creating a Culture of Health and Wellness, the National Business Coalition on Health, and the National FBI Academy. He is here today to talk about do the right thing and get paid for it, a preventive approach to healthcare. Ladies and gentlemen, please welcome Mr. Rich Shaw.
Good morning, everybody. I apologize for this bass voice. I'm getting over a cold, so I'm normally a tenor, but obviously we have an intimate crowd here, so please, as I'm speaking through any of this, if you have any questions or any comments, don't hesitate. It's funny when you do a bio like that, let's say what you did, 35 years of business, which means I started around the age of 10. But it's why do you do what you do? For me, I know this is an economic forum, but at the same time, and I'll speak to a lot of those things as well, the economy and how it affects us in the healthcare industry. But why am I here? Why do I do what I do? Because that's really more important when you're coming from the healthcare business. My business partner, I think, is going to be showing up here soon, Tom Hall. He and I met as freshmen at the University of Delaware. He wanted to follow his brother's footsteps. His brother was an All-American football player who unfortunately passed away of cancer about 9 months prior to him coming in as a freshman. We're both athletes. We're going to come in and we're going to take over the world. Now, a couple years go by, riddled with injuries. His football career is over. My distance running career is over. Pretty much saying, okay, what are we going to do to dedicate our lives to? What are we really going to do? We were fortunate enough that there was a professor at the University of Delaware, Dr. Bob Means, who mentored us and really gave us all the ability, the skill set to do what we do today. And we graduate. I go to South Carolina to do some teaching. Tom's working with some docs doing some rehab. And then my mother unfortunately passed away at 49. So I'm like, all right, back to Delaware. And I'm going to now dedicate myself to really helping other people. He says to me, Rich, I'm going to do this rehab center, but there's something else we're going to do. It's called a Preventative Medicine Center. Okay? Will you run? Yeah, sure. I'm going to dedicate my life to really helping people so they won't get sick. And that's really about 95% of what Cardio-Kinetics does today. I don't mean that as a commercial for us. I really don't. That's not what I'm saying. But when I'm speaking to you about why we do what we do and why you as business people and leaders in the industry, why would you want to do certain things for your employees, people that you know, there's a reason behind it. And it's not just money, right? Even though we think that that's a driving force behind a lot of things. It's not just money, there's a purpose behind it. And I think that you'll really start to grasp when I start taking you through some of the things I'm going to take you through today. Okay? So, you see the first slide, do the right thing and get paid for it. Preventive approach to health, right? Well, when you start talking to people, and like myself, who've been around forever, essentially, and you start thinking back to the 80s, when we started business, companies would look at us like we were crazy. I mean, they really would. We would say, you know what? You should really help your employees get healthier. And here's why. And you're like, what are you talking about? That's just, they'll be fine. We just give them their benefits and off they go. Here's their free credit card. You go and you just use it however you wanted to. There was no connection to benefits at all. Okay? Now, in the last 5 years especially, even closer to 10 years, we've seen a tremendous change in that, where a lot of the programming that's going on, when you're talking about preventive medicine, wellness, I hate the term wellness, quite frankly, because I don't know what it means anymore, but preventive medicine, really trying to help people really prevent themselves from really getting sick. Now it's directly tied and connected to the benefits programs. So I'm going to take you through some things, but first, you probably can't see that, can you? Get a pillar there.
I can see the flag, that's what's important.
You just see the flag. We might need to shift that, I think, for those folks to see that. We need to shift your table. It's one of the two. Do you want to do
I make that move, Rich. That's awesome.
Would that be? What do you think of that? Kind of comes
Jump right here.
Would you mind?
Not at all.
Because otherwise you won't be able to see.
You moved over here.
You can't see the words. You can't see the words are kind of funny. I'll stand over this one.
Front and center.
So we have the best medical technology in the world, arguably, the United States does. But our health ranks around 37th in the world. And, you know, a lot of us are guilty of this, and I think most of us, men, I hate to say, we're the worst about this. We don't seek preventive health care, hardly at all. We just don't until we really get sick. Women, you're much more engaged in the medical community, typically through OBGYN, but we really don't do that at all. So we wait. We're waiting for that magic pill, something, oh, I'm sick, give me something, you're gonna make me better. While we're doing that, our health suffers tremendously. Okay, so that's really what we're looking at here in the United States. Now, I'm gonna take you a little trip down memory lane and have some fun with you. Some of you will not remember this, some of you will. Consuming one 12-ounce soft drink per day increases the child risk abuse by 60%. These are actual ads. You know, how soon does 2 sodas start getting your kid drinking Coca-Cola? 7-Up, you know, make them really healthy. This is weird. Why we have the youngest customers in the business. It's really where we came from. Somehow we survived. I'm still not sure how we survived. You know, our parents were smoking while they were pregnant, all these different things. Somehow we still made it through. This is really true when you look at some of the dietary habits that we have. Because what we're wondering is, or at least I'm wondering, we're ranked 37th in the world. How did we end up there? I mean, we're, you know, again, we're incredibly advanced in so many different ways. But our health suffers so much. How did we get there? Well, you know, 35% of American adults are obese, but almost 70% are either overweight or obese. We have a huge, about 7 out of 10 people. And you look at this and you start to think about what's the new norm? Because a lot of us, I'm not looking at anybody in the room, but a lot of us think, I'm not that bad. Look at the guy next to me, okay? And you start to think that way. Or you're at the beach and you're thinking, I'm okay. Yeah, I'm really not that bad. Think back to pictures of World War II. You'd see these guys coming, you know, to go into the service and all that kind of stuff. They were skinny to the ground. We almost were like, oh my gosh, you know, they're not healthy. No, they were normal. That's normal. But we've just kind of accepted the fact that this is what it's supposed to be like. But we also were, many years, taught very differently how to eat and what we should be doing. So this is incredible. If you look at this, you know, we beat everybody, right? There's the average is 17%. Oops. Here's 17%. Here we are. We're up to 33.8 in the United States. Mexico's a little behind us, Australia. Then we have the UK and all the way on to Japan. That's the obesity rate that we're looking at in the United States. It's pretty scary. If you think about it, a third of people are obese and overweight. We're in the obese category. What does it increase? Look at this, type 2 diabetes. You're 7 times greater risk of getting type 2 diabetes if you're obese. 6 times greater for high blood pressure, and so on. Significantly greater risk for developing those diseases just because of the person's weight. And I didn't even get into the other factors. Now, just imagine if you combine them. You're overweight and you smoke. You're overweight and have high cholesterol, whatever it may be. Wow, times are changing. We're doctors smoke camels and bears. 1 in every 5 deaths is due to cigarette smoking. It's the leading cause of preventable death in the United States. When we started in practice and we started doing our, and I should back up for a second, because not everybody knows what Cardio-Kinetics is and what we do. We have 3 cardiac rehabilitation centers. So we treat people after they've had heart attacks and bypass surgery. So cardiologists refer people to us for that particular service. And then we do corporate health screenings and all that, the preventive medicine side as well, run corporate fitness facilities. But when we first started in business, the head of cardiology at the hospital was an internist. Wasn't a cardiologist. Okay? So think about that. They didn't have cardiac rehabilitation in the state of Delaware. We had to make up codes at the hospital. Going to the insurance company and make up codes that wasn't even in existence. So then we would walk into physicians' offices and tell them about our services, and they would be sitting there lighting up and smoking in front of us. It was crazy. And we're looking at thinking, you know, and I'm not down on physicians, not at all. But the thinking was very, very different in that time period. Here comes my business partner, Tom Paul. Yes, we're just talking. We're just talking. So this is kind of where we started. You know, when we looked at trying to educate not just the people, the public, about what you could do and the power that you have to change things. We had to educate a whole nother community, the medical community, but not only about what we do, but why we're doing what we're doing for people. So it's really, really interesting. But you look at this particular habit, I mean, it's one of the most devastating habits that you could ever imagine. Personally, I lost my dad at 63 from lung cancer. His father at 51, my grandfather, so I don't smoke. But you know, you can look at those, how debilitating those diseases are, and how early it takes people's lives. Nearly 9 out of 10 smokers start smoking by the age of 18, and 99% start by the age of 26. The youth is not going in the right direction typically. Whether it's smoking, whether it's obesity, activity, it's incredible what we're starting to see. And that's next generations that are coming up are really not very healthy. We're going to see even more multitude of problems as we continue during this next century. 90% of lung cancer is due to tobacco use. Think about that. Just tobacco use. And 90% of lung cancers are fatal. Right? So, you know where I got this statistic? Dr. Bruce Panasek, thoracic surgeon. He removes lungs all day. He's like, look, when they get to me, I'm pretty much just putting a Band-Aid on it. Because 90% of the time, that's going to end up being fatal. So there are the kind of issues that we have to deal with. And I'm teaching and showing you this now because there's a reason behind why we should be trying to get employees to change those health habits. In 1968, no person over the age of 40 should engage in vigorous activity, mainly due to an increased risk of heart attack. That's what the AMA is telling us, right? Think about that for a second. So, I don't know how many people are over the age of 40 right now. They're sitting in this room, but that would have been back in the 60s and saying, no, stay inactive. We don't want you to have a heart attack. You know, and then we had all these people starting to, big push and running back in really the 70s. And basically medical was like, hey, we're going to have a bunch of dead joggers out there. Do not do that. My gosh, you're going to all die. You know, it's going to be dropping left and right. We shouldn't be doing that. Luckily, we didn't listen to that. Now, in 2013, exercise can be viewed as a preventative medical treatment like a pill, which should be taken on an almost daily basis. That's from the AHA, the American Heart Association. Do you know how many years we've fought with people trying to get them to say, look, getting people active is really going to change their mindset in so many different ways. We can really impact how they're going to view what they eat, their stress levels, everything else is so important to them. It's kind of the hub of the wheel. It's not everything. But it is what the driving force is. And finally, we're seeing this for decades. They would never ever tell us. They would, it's okay, yeah, you can do a little bit of exercise, that's fine. But really what you need to do is, don't eat eggs. No, do eat eggs. No, don't eat eggs. No, yes, now you can't eat eggs. We were flip-flopped all over the place. But now we know, when we look at this, this is really important. I can tell more about what kind of health issues, or your risk for developing health issues, just by knowing what your cardiovascular fitness level is. I really get more than doing a blood test and looking at whether glucose levels are high, cholesterol, whatever. If I put you on a treadmill, I can actually see, okay, how fit are you? And if you're really fit, and you're at what we call a 10 Met level, and I'm not at a 6 Met level, my risk for developing diseases goes significantly up just from that one factor alone. That's how powerful it is. So exercise is critically important too. 1980, all the way up to 2011. Look at the amount. 1 out of every 10 adults here says diabetes, and that number may double or triple by 2050. It's just epidemic, what we're seeing. Incredible. 1 out of 3 children born after the year 2000. Anybody have kids that are after 2000? Grandkids, all that kind of stuff? 1 out of 3, by the age of 14, a third of them will be type 2 diabetic, first time in the history of the United States. That generation may not outlive their parents. And think of that. So, when you look at employer programs, what we look at the impact you can have on not only the people that are sitting there, the employees, and trying to get them healthier, but what they can do for their families. And a lot of times, that's the driving force. Because a lot of times, I can't get you to change something for yourself, for whatever reason. But if you get them to do it, hey, look, if you're a role model for your child, you may help your child, then I might be able to get someone to do something. But that's what we're up against. Excuse me, try to get myself up to the barracks instead of these. It's higher than this. as many as 45% of adults don't get recommended health care. We spend 99% treating illness, about 1% on prevention. I can tell you, in all the programs that we look at, it's usually much higher than that. When you go to a group, we had one group, a pretty large group that we were testing, and we asked them, do you have a PCP? Do you have a primary care physician? But when a third tell you that, we don't even have, we don't even have a physician, what kind of recommended health care do you think they're going to get? They're not going to get it. They don't even have a physician. And then you start looking at those people and saying, well, you should be getting this screen done, that screen done, that screen done. We just don't do it. And again, men, I'll pick on us. We are incredible, I don't even know how to put it. We come up with so many defense mechanisms for why not to get something done. It's unbelievable. We make it up. And I found out very early in my career there's a huge difference between a man and a woman. When it comes to health, there's a lot of other differences, but when it comes to health, and our preventive center, we have a weight scale. One April Fool's Day, I thought it would really be funny to increase the weight by about 5 pounds. I thought that would be a good thing to do. So 2 guys walked in, they hopped on the scale, they weighed 5 pounds heavier, obviously. So I looked and said, hey, what have you been doing? Been eating? You need to change this, you need to do a little more exercise. 2 women came in right behind, weighed on the same scale, said nothing to me. Heck, so being in the business I'm in, I can ask these questions. So I came up and said, Lori, how you doing? How's your weight? And the woman looked at me and said, my weight's fine, but that scale's off by about 5 pounds. True story. Anyway, men and women, when we come in to look at your health, it's so funny how you perceive things. And I shouldn't generalize that much. But for the most part, when you get a male that's going to be screened at something, he's coming in with a macho attitude telling you, I'm going to be good. I'm going to show you how good I am. It doesn't matter whether the guy is 50 pounds overweight and hasn't done anything for 100 years. He's going to really show you. Women typically are going to say, I'm not going to be very good at this. I'm not going to do very well, all that kind of stuff. And you kick our butts almost all the time. Okay? How many men and women see out walking in the neighborhood, the guy's always behind? The guy's like a dog trying to catch up. Back to this. You need to get some recommended health care. It's amazing what we find when we're asking people, when we're screening and testing all these people, we're saying, look, have you had a mammogram? Have you had this? Have you had that? No, not really. I haven't done it yet. Holy cow, it's part of your plan to get this done. But we're so unaccustomed to doing prevention, it just really doesn't click with a lot of people. Ours versus these. More than half of all women over 65 are widows. Widows outnumber widowers by at least 3 to 1. Right? Again, you're beating this. Women see a doctor 3 times more than men. Every 50% of men do not do physicals or get their cholesterol checked. Right? Again, when you're looking at groups of people and trying to say, what are we going to do to impact the culture of a workplace? You have to look at your focus sometimes and say, okay, what are we going to do to change it? Because you're not all the same. Everybody's an individual. 41% of men over 50 not screened for prostate cancer, and 60% not screened for colon cancer. 1 out of 4 men said they would handle worries about health by waiting as long as possible before seeking help. Men just I'd rather not know, And Tom and I had an incredible experience one time. I'll never forget it. This goes way back in the early 80s, but it kind of captured what a lot of people think, men in particular. Again, we did a stress test on a man. It was a grossly abnormal stress test. He had serious heart disease. We knew that. So we turned to him with a physician in the room to speak to him about the issues. He sat down, put his hands over his ears. And that was the response. Now, terrible to see that. We could get through it more finally. But a lot of people really think that. They just don't put their hands over their ears like a child, just sit there. But he did it. I mean, he was like, I just don't want to hear that. We really need to work harder to get those kind of screenings done. This is what we see. Breast cancer screenings, 55%, cervical cancer, 79%, colon, 42%. So we're really not getting to everybody the way we should be. And what we can do when we have an employer we're working with them and we're doing some simple screenings, you can really engage people at a much higher level and drive them back to their physician, drive them to the specialist so they can get the appropriate screenings done. We hope that you guys see your doctor once a year. Everybody typically sees their dentist twice a year. Boy, we get our car serviced all the time. Absolutely. Everything we can do. We spend billions of dollars doing that for our cars. It comes to the person, you're like, no, I haven't done that for a few years. I haven't really done that. So you haven't had a checkup. But your Your cars get checked out plenty of times. So the thinking's a little bit backward in terms of personal health. We spend over twice as much per capita on healthcare as the average developed country. Look at that. Okay? I mean, U.S. again, we're just out there leading. Remember the previous statistic where we're leading the entire world in obesity. We're also leading in healthcare expenditure. It's phenomenal. It's unbelievable. Look at that from 1960. Now we're predicting up to 2018. Unbelievable per capita healthcare expenditures. Phenomenal. So it's a huge financial burden on who? The employers and the employees, because there's a lot of sharing going on there. And it really comes down to being accountable for what we're going to do to turn around those expenditures. All right, now I'm going to get into it. Now I give you a background of why I'm going to talk to you about what can happen in the workplace to really drive change in the workplace at many different levels. But I wanted you to first understand that part. But before I go any further, we talked about screens, all these things I talked about, heart disease and cancers and all that kind of stuff. I talked to you about them, and you're kind of sitting there thinking, yeah, whatever. And it's kind of in one ear and out the other. All right, they're sound like, yeah. But why do we do that? Well, for one thing, heart disease is the #1 killer in the United States. It's responsible for almost half the deaths in the U.S. Think about that. If I told you today that there's a virus, you don't want to end up talking like this. There's a virus. And if the people in the United States get this, it's going to be responsible for almost half the deaths that we have in the United States. You'd be like, what do I do to not get that virus? Heart disease, we don't take it that way. Kind of like, yeah, I'll be okay. You'll put a stent in, right? You'll bypass me, you'll do something, whatever. You'll take care of it. Problem is, majority of people, over 40%, about 44% of people, the first sign that they have a heart attack, or a heart problem, is a fatal heart attack. Right? So we're not around it when we talk about that. So for some reason we don't screen this guy very well. This is a real human heart. This is not a model. Right? That's the real deal. Right? It came out of Delaware, Johns Hopkins University, it's the University of Delaware, where that's in fact it's been rubberized. Where'd Jim go? He left, didn't he? I wanted to see him pass out. He said, I don't want to see that heart. He said, I'm going to pass out for sure. When you go to anybody, employees, employers, and you're trying to get them to understand, why do you offer services to your employees? Why are you doing it? A lot of them are like, oh, well, we got to keep our healthcare expenditures down. We really got to keep those down. So benefits, costs are going. Yeah, that's true. But let's back up for a second. You want to offer certain types of screenings. Why do you do those? And what we typically find, we say, look, you have to teach them and say, look, there's a reason why your cholesterol level should be checked. There's a reason why your blood pressure should be checked. There's a reason behind looking at EKGs and all that kind of stuff. There's a purpose behind that. Because these arteries lying on the outside of the heart, they're the only thing that's keeping you alive. See that big left artery? You have a little smaller one on the right, and you have a circumflex on the back. Right now you're sitting there, heart can't stop, and you have to make sure it has enough oxygen. That's the only thing that will give you oxygen, are those arteries. At their widest point, they're an eighth of an inch in diameter. So if somebody says, the catheterization wasn't too bad, I have a 50% blockage. Okay, so that was the widest point. Now it went down to an eighth of an inch, let's say, or less. It's barely squirting the blood through there. Okay? We really want to make sure you keep those open. And those risk factors influence the health of those arteries. Okay? That's some of the things that when you look at employee groups, you say we need to create awareness. What drives me crazy sometimes is the awareness is we're just going to throw out a bunch of information to them and hope something sticks. It's like, no, you have to engage them. You have to make it personal. It has to be personal for them. They have to understand and grasp it. You have to do things that really, truly teach them. Pass that around. Mark told me to do that, see if I can get a reaction. All right, leadership's role in establishing successful outcomes. The leadership of any organization is critical to the success of getting people to improve their health. It really is truly, truly, truly critical. If they're not championed, they're not engaged, it's going to fail. Here. We really need that support and help. And the people that do that is tremendous, tremendous improvements. First thing you need to do when you're looking at saying, okay, what am I going to do to affect this huge benefits program that I have in my company? Everybody sat there, you've changed plans a million times. You guys all know that. You change this, you change whatever. But what you really started to do first is you need to lead by example. If you want to get employers engaged, take the leadership and make them go through the screenings. And if they're willing to do it, make it public. Would you like to do this in front of your employees? Have you go to the screening? We'll put you on a treadmill. We'll do it. Would you be willing to do that? The ones that do it, it's unbelievable. Like, oh my gosh. Even if they don't like their employer or like the boss, like, if he's willing to do that or she's willing to do that, I think I might too. You really need to think about engaging them, because it's one of the first things that gets them to understand why they're doing it, as opposed to, hey guys, this will be good for you to do. I'll see you later. I'm just going to go get my executive physical. I'll see you guys later. It's like, no, we need to engage them at a very high level. Show that you care about the employees. The leadership has to absolutely say that. And it's an interesting thing, but you're walking a fine line. An employer has to say, I care about you, I want you, but I don't want to know your results. It's one of the first things you'll hear from people is, if you look down at the bottom, is a confidentiality issue. Oh, my employer's trying to get rid of me. They want to know if I'm unhealthy so they can get rid of me. No, they're not. They can't. Obviously, we have so many HIPAA laws now, it's impossible for that to happen. You can't do that. That's what you need to do. They need to show that they care and explain how they play a role in the benefits package. They have to understand that. We had Wawa. I'll never forget it. Self-insured, one of our clients. And we're explaining to their pretty high-level management group, you're self-insured. They're like, what does that mean? They really didn't know that it was their bucket of money that they were drawing from for their medical costs. They really didn't understand it. So there's a lot of education has to occur explaining how that a positive message has to come across as being positive. All right, first step. Health affects the company's healthcare costs. Everybody knows the 20-80 rule. 20% of the employees are driving up 80% of the costs and all that kind of stuff. What they don't think about a lot of times is that 20% is such a dynamic group. Because there are people coming in and out of that 20% all the time. When you look at screening programs, what we would love to do, you do a screening, let's say you test 500 people, and you come back to them and say, okay, here are all the people that had abnormal results. So it's 50%. The other 50%, you didn't have abnormal results, but you may have had a lot of lifestyle issues. And if we could just get them to just stay where they are, you say, look, don't get worse. Just don't get worse. Stay where you are while I concentrate on these other guys who really have abnormal results. Just stay there. But they don't. They don't. Most of them would think, I'm okay. I dodged the bullet. No, I know I'm smoking and drinking too much and I'm not exercising enough. My blood results are not great, but they're okay. They're not abnormal. I'll be fine. And the next year you come back and, no, they're abnormal. Now you have high blood pressure, you have high cholesterol, you have all these other things. And that's a major factor. So they get them to understand how their health can influence those benefit costs. They don't really get it. They just think it's a game. And we have to engage them. Here are the things typically you can control, the things that you can't. You can't control your family history, even though you might want to change who your family is. You can't do that. You can't change your age. It's not easy to change your gender. And your past personal history. Okay? So they're the things you can't control. They're the other factors mainly that you can't control. All right? Now, giving people the power to understand what they can do to change that is the most important piece of that. Getting paid to do the right thing. All right. Now, you go out and screen people. You screen them, you give them results. They look at those results, and it's kind of like, okay, now what are they going to do about it? And you give them all these great action plans, you do many different things you want them to do. But you have to grab their attention. The people that usually have abnormal results, you have some fair amount of success with them. Because they're immediate. If you have an abnormal result, you need to change that. This isn't just about losing some weight and exercising. We really need to get you to change that habit, change that result. Here's what you need to do to do that. That's the kind of discussion. So that's a much more pointed discussion. But for all those other people, you're looking at and saying, what are we going to do? 58% of wellness programs fail due to a lack of incentives for participating employees. As soon as you put the incentives in, it really drives up not just participation, but change in their health habits. And I know a lot of people look at that and say, do I really need to pay somebody to get healthy? Should they want to be healthy? What I normally say back to them is, well, when most people want to be safe at the workplace, well, then why do you have all these safety programs in place? You have to teach people how to be safe. Do you think they want to be safe? Do they want to get hurt? No. Well, really do want to get healthier too, if you ask, I've never had somebody when I say to them, is there anybody here that wants to be less healthy than what they are now? I've never seen them, oh yeah, I just can't wait. You want to increase that by giving them some incentive, some focus on what they need to do to improve their health. And it really is very, 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 very powerful. Provide the first year, what we found is very, very, very important to do. You want to get them to participate. So you're going to offer some kind of incentive, anything that's going to get them to at least say, I have no reason not to do this. I mean, they're letting me do this, they're giving it to me. I'm doing it on company time. Why don't you want to do it? And normally the people that do not want to do it are afraid of the result. And again, people pick on those guys, and it's usually us. And we come up with all kinds of defense mechanisms. Oh, they're just trying to get rid of me. They're trying to do this to me. They're up to something. I have all this, and it's like, no, there's every reason to participate. So you want to give them some type of incentive. You have such a teachable moment. When you see people going through health preventive screenings, we're part of the medical community. We see how it does not work on your behalf a lot of times. So how many times you get the test done? You get the test, the technician looks at you and goes, okay, we'll call you when the results come in. And you're looking at it and saying, was that a good? I think they look positive, like my result will be a good one. Or is that a bad one? You have no idea what that result is. And you're thinking, I hope it comes back okay. You have a moment right there when you're screening people. You should take advantage of that and teach them what it means, even if they have a normal result. How often do you get a result back and you have a whole bunch of blood results, and then there's one line that's red that says it was out of range. And that's all you talk about, is that one. What about all those other factors? Maybe they were normal, but are they going to be normal the next time? You need to understand this. So it's really important to look at that teachable moment and make sure that there are other ways of interacting with those employees throughout the year that are fun. It has to be fun. I was just telling a story before we came in here. Artesian Waters, my client, a lot of blue-collar workers, we were being asked to develop a weight loss challenge program. We're thinking, these guys are going to really get involved and really want to do this thing. Is it really going to be something that they're going to even be least bit interested in? Well, they had a huge percentage participation in it. But better than that, they made it team competitions. They're naming their team. Big Daddies is the group that won, right? They had some Big Daddies. They did have Big Daddies. But they won. But it became such a fun, engaging way to get them. And once we were done that, the CEO, Diane Taylor, says, we need another one of those. We need another one of those. And that's, you need to continue looking at creative ways to engage people, make it interesting and fun, while along the way they're improving their health without even thinking about it. Okay? Any questions so far?
So in terms of engaging the employees, and I understand about putting the incentives in place, what's the measurement period, if you will, that would actually affect an outcome versus just, oh, give me the gift card or give me the day off, after that period of time where the incentive says, oh, we're going to give you 3 months and the biggest weight challenge whoever wins, you get a day off or whatever. Is that really changing their lifestyle? Would you say in all of your experience it takes a year, you're saying a year or so?
So you're talking about the health outcome, right? Not the health expenditure outcome yet, because the health outcome of the individual will happen fairly quickly in a couple of different levels. So you have the people that have an abnormal result, we'll see a very quick change in improving that result fairly quickly, because you're driving that really hard, so I don't want them to have a serious health issue. When you're getting lifestyle habit changes, which you're really referring to, what drives them to get that change? Very difficult question to answer, because I can tell you that there's a fairly significant large group of people that will make changes. But you have that other group that's sitting there that's waiting to just see, I don't want to do anything until I see what all my other buddies are doing, and then maybe I'll jump in and start participating. So you have that other little group. The other people, to get them to really get engaged and change, is when we get into, kind of jump ahead a little bit, when you get into criteria-based programs where people are having to meet certain healthy criteria, and then their benefits, they'll pay less than the benefits for doing that, that's when we start to really see people get engaged, and you see sustainable lifestyle changes over time, which is really cool. I think I'm going to show you that in just a second. The other thing we think is very important is share back to the employees. Don't hide it. It's like, all right, we have all this aggregate data, we have all this tremendous information about, we kind of talked about, like, you're your own country now. Forget how we're comparing you to other people in the country. You're your own country. What do you look like? This is your first year. What are we going to do to make a change for the second year? And you share that back with them, and they really start looking at it. I think it's really cool. You give a person back your results. Right? So now they're sitting there again. You've already tested them. They've already seen this. But now they're sitting in front of everybody in the room, and they have their results. They're looking at it. And we explain to them, if you have a red bar graph under heart disease, you have a red bar where it says diabetes, a red bar where it says stroke, that means you're at the highest risk for developing that health problem. So then you look and you go, well, we tested 100 of you, and 20 of you had the red bar for heart disease, and they're sitting there looking going, shoot, I'm one of the 20. Oh my gosh, I thought everybody had these problems. It's like, no, you're just one of the 20. The impact on that is phenomenal. You should see the light switches going off. We did that with a group called Horizon Services. Unbelievable. You should have seen how they were all sitting in a room. Next thing you know, it's all confidential. Everything's confidential. They're sitting like this. They just start yelling out at each other. They're going like, dude, I know you have a problem. It's one of the best things that ever happened, because they all started talking, even though they're cutting each other up. They started talking like, oh my gosh, and they made phenomenal changes in doing it. So you got to share with them what was good, what was bad, what was ugly, and introduce a long-range plan. This is an example of incentives that we really see. I put up 1 point, but 1 point could be whatever that employer wants it to be. You participate. Now, federal guidelines are allowing that to increase. Now, first of all, federal guidelines, if you want to incentivize somebody to participate in a health screening program, you can make whatever you want. There's no percentage guidelines until you start meeting criteria. Participation, you can say to people, okay, you don't want to participate in? That's fine. You're going to pay $5,000 to get in our benefits program. I was like, whoa, really? No, nobody's done that yet. I've seen 1,000. People say you're going to spend $1,000. It's going to cost you $1,000 to get into our plan. You can do anything you want with participation. People don't normally do that high, but you can. But a lot of times, then you look at all these points, and these are just some of the values that you can use. You can now, in 2015, go up to 30% of what that person's, that single payer in that plan, whatever they're paying, whatever they're contributing, you can go up to 30%. You can incentivize up to 30% starting in year 2015. So it's been 20% prior to that. So you might look at this and say, 1 point for participating. Well, what's the 1 point worth? I'll make it 10%. Whatever. You want to make it something that's going to get the United States. So look, if you just participate, you're going to pay 10% less into your benefits program. That's one way of doing it. Or you can say you're going to pay 10% more. It's either the carrot or the stick. Which one do you think works better? Carrot usually works better, but it depends on the workforce. I've seen some where you don't quite get that. You have to almost look at it and go, all right, you're going to have to pay more. I'm going to penalize you. You have to go. And it depends on that employer-employee relationship, what you get through them. Sometimes people do a little bit of both. I'm going to incentivize you if you're doing these things well, but if you do this bad, you smoke, I'm going to kill you. I'm going to get you really hard, all right? So it just depends on how you want to come across. I've seen so many different employers approach it kind of the wrong way. I would say the wrong way, meaning that whether it's a carrot or a stick, you're still making a positive message. Because even if you're saying that you're going to have to pay more into your program, what you should be saying is, look, all you got to do is meet this, and we're going to show you how to meet this criteria, and then nothing happens to you. So you can put a positive spin. You can see, since we're the guys that do the screening, we want to be the good guys. So we would never want to come into somebody and say to you, oh, you failed that one. Failed that one. You're going to be paying a lot more. Like be a jerk about it. You have to get them to want to follow your lead. So we want to be positive about it. What we get excited about, see all these different measurements we have up there? You're teaching people what they should be, where they should be. And they remember it. Until the incentive's in place, they forget it. It's like, I don't know. What was your LDL? I don't know. What's an LDL? What was your blood? I don't know. They tell me it was normal. I don't know. Whatever it is, it's good. And I'm saying, well, no, as soon as you put a game to it, you put some points to it, they remember it. Very, very, very well. They remember it. They won't ever forget it. Look at body mass index. Whoever came up with the word obese for being greater than 30 BMI, like to shoot, because it's not fair. When you think of obese, you think of obese, like Java Hut type of obese, right? So, all right, somebody's telling me, so we have to sit in front of somebody and say, all right, I'll pick on Lori, saying, Lori, you're not obese. So I look at Lori and I say, Lori, your body mass index is 31, so you're obese, right? Well, every word after that she doesn't hear. All I remember is that because sure, you call me obese. All I remember. I just wish somebody would come up with that, because all I want to say to you is, you're at 31, and I want to get you to 29, and then to 27, and then to 25. That's all I want you to remember. But for whatever reason, you have to categorize people, and it drives me nuts. But to encourage people, this is the only factor that we really look at and say, okay, can you be less than 30? We'll give you a point. But a lot of people go, well, these guys lift weights, like, yeah, I lift weights, I'm really muscular, so my weight's going to be higher. I'm not going to be below 30. So, well, if that's the case, then your waist measurement should be less than 40, right? Because you should be thin. The guy's like, no, it's not less than 40. It's like, all right, then you're overweight too. All right, so you give them an either or a person could lose a couple BMI points. It's about 12 to 15 pound weight loss. So you're trying to be encouraging to say, all right, look, you're at 40 BMI. You're not going to get to 30 BMI by the next year. All right, it could. It would be highly, highly, highly unlikely somebody's going to do that. So you're saying, all right, look, we just want to encourage that to go in the right direction. Right, so there's ways to engage those people for that point. So maybe give them 2% for getting to that. Blood pressure, look at that, we're just asking people, think about that. I'm going to make you pay less a year in your health care if you just don't have an abnormal blood pressure. I didn't ask you to be 120 over 80 or better. That's ideal. I'm just saying, no, just don't be abnormal. Same thing with lipids. They're all abnormal results. If your LDL level is above 130, it should be under 100. If you're a cardiac patient, like 70 or under. So we're just saying you don't have an abnormal result. So that's the messaging that should go out to the people, to the employees, is we don't want you to be abnormal, right? In a lot of ways. But we don't want you to have abnormal results. If you don't have that, we know that those healthcare costs are going to come way down. We know that. What we hope should happen is there's actually a spike in what people are getting in preventive screenings. We did a study with the state of Delaware, 1,500 people. Governor Minner actually got a national award for it from the Council of State Governments. Phenomenal health reports. The people that had incentives, Tom and I were sitting there waiting, this guy's getting up to give a big talk on health and human services, and they had this consultant in there, and we don't even know what the results show. We don't know what the health expenditures say. We're sitting there, is it going to be good or bad? Because what we knew was, we saw these health risk factors going down significantly in this program, and there were incentives and all this kind of stuff. Wow, this is awesome. But in a year, is it going to change healthcare expenditures? That's not a lot of time. And wow, is it going to do it? Well, there were 500 people that got an incentive of those 1,500. So we had different plans. But those people that had incentives, they actually had a little bit of a bump in theirs. But when they dove further, it was all preventive type stuff. They're like, wow, that's awesome. But their ER visits went way down. All these other things went down. They're all going in the right direction. They just had a bump in those one areas. And the statement at the end was just awesome. It said, this is the best program they've ever seen in reducing people's health risks that's going to result in tremendous healthcare reductions in expenditures. The consultant, the guy that they had hired, he'd never seen anything like it before. And it actually won government in that national. That's how awesome it was. And a lot of it had to do tied to those incentives. That's what it really was. Now, and then glucose, diabetes. We're asking people just not to have over 100. To think about that, you don't want to have a pre-diabetic or diabetic glucose level, and then you get a point. So next, smoking. Smoking's the tough one. How are you going to do it? Typically, when you're engaging employees, it's really hard. So if you have smokers sitting in the room, as soon as you throw this up, they're already going like this. Like, they're picking on us already. They're picking on us smokers. That's why you just embed it into all those other things. Don't just pick out smoking. A lot of times they just say, okay, if you're a smoker, it's a surcharge, boom, off you go. And you can do that, it's fine, it's okay. But normally it's next year you embed it into, look, that's just one of the habits. And you can do a test for it, so it shows your carbon monoxide levels. And you ask them to sign an affidavit that says, I'm not going to use tobacco. So don't lie to your employer. Right? That's basically what you're asking them to do for the next year. Yes, sir.
I think there's a fine line in smoking when it comes to habitual cigarette smoking and an occasional cigar, and it's hard to say I'm not smoking,
right.
But 1 or 2 cigars a year I find, or I don't think is anywhere comparable to the same health effect.
I agree, and it's a really, I had the very same question asked to me last week after presentation.
I don't see cigar smokers not talking about this.
And the basic answer is, you answer it as honestly as you think you can. So,
Well, they think of that hard rule of no tobacco use, it really doesn't allow for that.
And really what you're talking about is habitual smoking habits.
Yeah.
Or tobacco use. You're really talking about habitual. So there's a way to write that says, I'm not going to be a habitual tobacco user or whatever. There's ways to write it so it's better. So essentially, you'd hope that people don't smoke at all. That would be ideal. But at the same time, no, that's not really what you're after.
I think that multiple tiers, multiple points, because body mass index over time could be point to this point, to this point, to this point, to this as you improve. Same with this much smoking versus that much smoking versus.
And it's hard to measure that. It is. And it's hard to police. I mean, most employers are going around trying to police, I saw you smoking, I saw you at the bar smoking, or I saw you outside, whatever. You're not really going to police it. You're pretty much looking for an honor system of saying, and the honor system is, you're not going to be a habitual smoker. That's really what you're asking.
Is there a test that correlates to impact of the smoking, like the carbon monoxide?
Yes.
Say you're hurting yourself this much.
Yes, because if I did a test on you now, and you're a non-smoker, you should be close to 0 or at least under 5 parts per million of carbon monoxide. If you're smoking, say a pack a day or more, it might be between 10 and 20 parts per million. More than that, we'll get up to 20 plus.
Can you put a carbon monoxide thing on there instead of a yes or
We
no
do.
smoking thing?
We do both.
Okay.
We do both. So we just say, hey, look, take the test, okay? And we ask you to sign the things. So
That's a much better honor code, I think, to just say,
Yeah.
this is a number and you can't refute whether you're impacting your body or not.
Yeah, so you can do it both ways. It depends on the employer, what they're wanting, and how they want to do it, how they want to approach smoking. A lot of times they approach smoking very differently because they're trying to get no tobacco use in their campus in particular. They're like, okay, no smoking here at all, that type of thing. No smoking in your trucks or whatever it may be. They'll do those things. So they're trying to send a harder message to them in that regard. But usually we do both. You would test the person and you're asking them, all right, you're going to say you're not going to be using it also. But it's hard to tier. It wouldn't be like I tier it. You're at 10 parts per million. You're at 20 parts per million. Look, if you're there, that's bad. You shouldn't have that. And you can even see people with secondhand smoke. If they come right in, it could be high also.
And then they will not be a smoker and see if they're being impacted and say, oh, I'm not a smoker. My household is hurting me and I need to talk to my household.
And that's where we had it happen. We had a guy come in for just a promo. The guy was coming in as a leader of the company. So he come in, hit screen. He's like, I don't smoke. We're like, well, your carbon monoxide levels are really high, Were you sitting in a garage with a bunch of cars turned on, or what were you doing? I was like, what happened? And he goes, oh, but my wife smokes. Like, well, guess what? It's impacting you. You look like you're a smoker. It's pretty funny. We talk about all the confidentiality things and everything that we go through. And when it comes to smoking, we can't share results with anybody and all that stuff. We had this one company where spouses could get screened also. So husband's in one room, his wife's in the other room. They come out to compare results, obviously. Afterward, he didn't pass the smoking. And so she starts getting upset with us, saying, he's not a smoker, how did that happen? We're looking at her like, we can't tell you. Only he can share results with, we can't say anything. So anyway, you get to see this husband and wife fighting over the fact that he's been hiding, he's been smoking. And so then we started marriage counseling, and but it really is kind of a sensitive subject when you come to some of those factors. But smoking's a hot button with a lot of people because they feel like you're now being even more intrusive of telling them what you can and can't do.
Like if they gave me an incentive of a good cigar once a year, that would be for me. Now they don't do this, so it's like motivate me to do one thing right for that other.
And you're not looking for that casual smoker. That's not what you're looking for at all. And they would pass. They should pass with flying colors. So we've even seen people quit smoking trying to beat the test. So they know they're going to get tested. So maybe if I stop for a couple weeks, I'll pass the test. And then I end up stopping smoking. We're like, great. And that's what we were after doing. So from where we come from, though, we're just trying to teach you why you need to be there. They're more interested in the money. Really. That's their motivation. These are actual, and I'm going to go say the employers were, these are actual results of Delaware companies. And look at this. This black bar is the national average. So with diabetic glucose, LDL, bad cholesterol, metabolic syndrome, high blood pressure. Metabolic syndrome is if you have like 3 or more major health risks, that puts you at a much greater risk of developing all diseases, in particular heart disease, cancer, and diabetes. So we really look at that. That's a major one. But look at this group. How many people had high blood pressure, how it went down. And then metabolic, down. LDLs down. A little bump in the glucose levels. Diabetic glucose, that's glucose levels above 126. It was pretty high. So it was really significant. So we saw that over a 3-year time period. So it really does make a difference. And this is a blue-collar group we were working with. And it also was a leader of a company that didn't believe it was going to work. Seriously. I mean, he basically looked at me the first time I ever met him. He was just looking at me and goes, this is a bunch of BS. He didn't say that, he said a lot worse. But this is a lot of BS. My guys will never change. This is not going to work. It's not going to work. I said, just go through the screen and experience it and then tell me what you think. Okay, maybe, but I'm not convinced. And then this guy turned around and he's been one of the biggest champions I've ever seen. It's phenomenal. It's done just tremendous work. And then look at this. This is people at risk, at really high risk for developing diabetes, heart disease, stroke, and heart failure. And look at how those lines all came down, except for stroke stayed the same in that 3rd year. But they really significantly came down. That's most important. If I sit here and talk about abnormal results, I'm saying, okay, I want to know about abnormal results. Really what I want to tell you too is don't develop the disease. That's even as important. And then look at all these other improvements. I mean, this is Delaware companies. It's really making a significant change in people's actual real results. And then bottom line results. What they're going to save like $500,000 over a 5-year period. It's pretty powerful. And then who benefits? You look at this, you get to the end of the day, and you say, okay, who's really benefiting? First of all, people. Lives are improved and saved. I mean, that's really, really true. I can't tell you how many people that we see that write us emails, notes, or on video saying, thank you. If we didn't have this, I would not be here today. Because I found out the following about me, that led to this. Granted, it's not a huge percentage of people, but it's a percentage of people that save lives and the employer impacted them. It's very, very important. And both save money. It really does. I mean, we've seen real healthcare expenditure in self-insured companies go down. And then a lot of times it's, well, if you just stay the same, so you're not getting 8, 10, 12% increases, which you typically see. But we really see that driven down. And then why? You want to take care of those costs, the healthcare costs, but you want to change the culture of that company. It really needs to change. It has to be out front. It's not something hidden behind the scenes of, these personal health things. It's not our business. Yeah, it is your business. And then when? Ignoring these challenges, it's not going to go away. It's like health, I hope it goes away, and then I'll just ignore it, maybe it'll go away. No, you got to engage it as soon as possible. The sooner the better, because that's really going to make a huge impact. Questions, comments, thoughts, ideas. You're sitting there very quiet. I see it not in your head. Yes.
You put stroke up there. How do you measure risk for stroke?
It's a number of factors. Blood pressure obviously is going to be one. Blood lipids are another also. So, and then age. I hate to say it, but as you get older, you also become at a higher risk, and in particular that and heart failure are a couple of very major risks. So when we go into groups, a lot of times one of the number ones is blood pressure. You want to see where's that group and where are their hypertensive rates, and then you want to look at other factors in their blood lipids and how they combine. It's more important how the factors combine. And when you look at, I don't mean this as an advertisement for us, I really don't, but we have a really unique tool that we use, and it's a morbidity-based model. So if the algorithms that are in there are predicting what are your risks for developing diseases, as opposed to a mortality one, which is just saying, what are you going to die from? So if I did a test and you say, well, you look like you're going to die of heart disease. When? When you're 90, whatever, but you're definitely going to die of heart disease. Well, that's not very impactful. You really want to say, no, what is your risk for developing heart disease, let's say in the next several years, and what would you do to alter that risk? You would need to change this, 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 and this. And the tool's cool because if you said stroke, we have a graphic that's really neat. It just says, well, you're at high risk for stroke because of this factor, and this factor. So you can change this and this pretty easily. This one might be a little tougher. At least let's try to attack those two. So that's really the type of engagement you should have that's missing in most of the companies that are offering services like that. And again, I don't mean that, Cardio-Kinetics is great. I'm just saying, if you're going to engage employees, you need to use that teachable moment to really get them to understand what are you going to do to change it so you're at a lower risk so you don't develop this kind of health issues. Other questions or comments? Yes, sir.
How long does the screening process take?
30 minutes or less. when you're doing like a biometric screen, we don't even like to call it biometric. We do it because biometrics a lot of times are just, too often it's just like a tech going out, sticking somebody's, here's your results, and off you go. It's more of a health screen. But we also do a lot of exercise EKG assessments, and that's usually another half hour when we do that also, because that can really detect underlying coronary disease also. And that's one of the things that's missing. You know, I mean, how many of you guys have ever had a treadmill test done? Don't raise your hand. You only have time because I was doing the VO2. How many of you had it done? I mean, not many people get it done. It's really interesting. They don't think to do them because they wait until you have symptoms. If you wanted to get your insurance paid for, you're going to go in and say, I'm short of breath, I'm having chest pain. Oh, okay, now I'll test you. What if they did that with mammography? Okay, prove to me you have a lump in your breast. Okay, now I'll go back and you'd laugh. With heart disease, they're like, we'll wait till you're symptomatic, now we will screen you. It's backward. It really is. It's kind of slow. Any other questions?
Out of curiosity, and not to get political, but you've seen a lot of data. What do you think of the Affordable Health Care Act as it reflects with what you do?
Why did I ask you that?
Oh, gosh. In the written word, it should drive a lot of people to us because they're supposed to be encouraging preventive care. So it should do that. At the same time, as you all know, in the insurance world, employers are automatically bumping up costs right out of the gate because they don't know what's going to affect them. So like, okay, you're telling me I'm going to have a 10% increase. Well, I'm going to increase another 2, 3, 4, 5% just because I don't know what's going to happen. So far, it hasn't impacted us as far as people saying, I'm not going to do this because, I don't know, heck, just here's your $5,000. I'm walking away from this. We haven't seen that yet, but I'll be honest with you, I really hope it reverses itself. I hope they change a lot in that Affordable Care Act because the employers are just going to end up paying, and employees pay for everyone else that doesn't have insurance, essentially, is the way it seems. So that employer is running a little scared right now. That's what we see. They haven't completely just said that's it, but it's a concern.
Healthcare costs, the rates that you put up on there, it almost seems like it incentivizes you to not pay attention to the Affordable Health Care Act, not what you guys do.
You're right.
Better go to the next session about the Affordable Care
That's
Act.
right. Yeah, and I've been in many sessions when they go over all of the different rules and laws and all that kind of stuff, and it's so complex. Nobody really completely can. We know it's going to be impactful. Obviously, it already is. We're hoping that the employers still come back and go, all right, look, we can still control this. We can control these factors, and in particular the ones that are self-insured. So far, we have not seen a direct impact. And again, the way it's written, I think people will be coming to us more because they're really supposed to be pushing preventive care. But it's who pays for that. Yeah. It's not, we all know who's going to pay for that. It's everybody sitting in this room. So I'm not getting too political. You get your Bible, but anyway, I think it's a.
Rich, do you see more companies going towards self-insuring?
Yes, we have, and smaller groups that we didn't shoot time on for years. Oh my gosh, really low numbers. And well, Jim, you got yourself insured with 150 employees. He was just telling me that, which was really cool. And I was like, man, I can tell you, years back, we went close to that. I said, well, what was the client? Well, 5 years ago, I think they went self-insured. They have 8,000 people on a plan. And up to that point, they weren't self-insured. I was like, really? I said, wow. But we're seeing more and more people going in that direction because you can control it with cap loss and all that kind of stuff that you have to also have in there. But it really is which is really, really awesome because now it's their money that they're controlling. And, we can see direct impact. Like, look, let's look at, they're your dollars. What happened this year versus this year? And so we're seeing a lot more people going that way, which I think is very healthy for us too.
Any more questions for Rich? Want to keep these on time?
I don't have a question, but I have a comment. So I was an employee of a very large company here in Delaware, and we did the biometric screening, the little pinprick that Rich had referred to. And then Becky, a colleague, and I went and we had the screening at Cardio-Kinetics, not even close in terms of making a comparison. So I encourage everybody, not that you know me from Adam, but I encourage everybody to experience it because it is pretty groundbreaking.
Thank you.
You're going to pay her.
And they didn't pay me for that.
There you go.
I'll take the credit card.
Hey, everybody, thanks for your time and attention. Once again, let's give a big hand to Rich Shaw for spending time with us.